can see here, if you compare it to the African American and non-African American, there is a statistically significant difference. So it is a true genetic difference. So the Asian patients have a lower BMI and other different characteristics than Caucasian population. The previous studies on renal denervation have primarily included Caucasian patients. So the responses to denervation in Korean patients is limited, and also it is unclear whether the pathophysiology of resistance hypertension could be different in Asian patients, and whether any differences might affect the role of the sympathetic tone and then consequently renal denervation outcomes. So we reported a paper compared to evaluate the 6 and 12 months outcome after renal denervation in patients in Korea Global Registry to compare them the Caucasian patients. So from the Global Registry, we can divide GSR Asia Pacific countries and GSR outside the Asia Pacific countries. From the Asia Pacific country, we only adopt the Korean registry data. So 93 patients are enrolled in this study to compare the Caucasian patient. From the outside the Asia Pacific registry, we adopt a non-African descent and meet our GSR Korea inclusion-exclusion criteria. So 169 patients are enrolled to analysis of the effect of renal denervation. So this is baseline patient characteristics. The office systolic blood pressure is significantly lower in Korean patients, 168 versus 176 in Caucasian. In our patient, more younger and thinner and better renal function, and our patient have higher heart rate compared to the Caucasian, 72 versus 69. And what about the hypertensive medication number? So 3.7 versus 4.7. That's smaller drug we used. The AC and also we used infrequently in use AC inhibitor and aldosterone antagonist, the alpha adrenergic blocker compared to the Caucasian patient. The office blood pressure changes shown in this figure. At 6 months, there is no statistically significant difference between two groups. But at 12 months, in Korean patients, 27 millimeters of mercury systolic blood pressure drop, which is bigger than 20 millimeters of mercury drop in Caucasian. So similar in diastolic blood pressure. And also the responder rate is increasing from time. At 6 months there is no difference, but at 12 months the responder rate is higher compared to the Caucasian group. So from the multiple logistic regression analysis, and then we find a higher baseline of his systolic blood pressure was associated with a larger reduction in systolic blood pressure at both 6 and 12 months. It was notable, as previous analysis has consistently shown an association between a higher baseline of his blood pressure and a greater reduction in systolic blood pressure after denervation. And also, the current patient has a larger reduction in systolic blood pressure at 12 months, independent of baseline of his systolic pressure, as shown in this table. So, ladies and gentlemen, RDN in registry Korea subset provides a significant reduction in optic systolic blood pressure at 6 and 12 months compared to baseline. As compared to the GSL Caucasian subset, the reduction in systolic blood pressure in GSL Korea was similar at 6 months, but which was higher in 12 months. Even though fewer medications and lower systolic blood pressure at baseline, contrary to prior studies that consistently indicated a relationship between the baseline systolic blood pressure and RDN blood pressure lowering responses. A multivariate analysis orientation remains more likely to have a larger reduction in 12-month systolic blood pressure. So maybe a larger role of sympathotone in pathogenesis of hypertension in Korean or Asian patients compared to Caucasian patients. And finally, renal denervation with simplicity still show favorable safety results. Thank you for your
a wonderful summary of your experience. Is there any burning question on this presentation?
I have questions. Thank you very much for your beautiful result. So especially for even the lower baseline blood pressure levels, but the greater reduction was found in Korean populations. So I think why this happened. So which component will be determine such a greater blood pressure reduction? The young girls, or one is the age, but the oppositely, obese or concomitant of the sleep apnea, should both these two conditions should be the responder of the renal denervation.
Yes.
What's your interpretation of this result?
Okay, thank you for your great comment about our results. And then I think there are two factors. First is patient factor, another is a procedural factor. The patient factor, as you point out, the younger patient. I think a younger patient has they don't have any irreversible change regarding the sympathetic system and then vasculature. And so that is one of the factors, and then the other factor is renal dysfunction is the negative factor for the positive renal denervation results, and also the drug responses. So we prescribe less drugs. That means this our patient population is very sensitive to the additional treatment. And the other is procedural factors. Procedure is very much dependent on the operator, as you find out in the hypertension 3 trial. So in experienced hand, there might be make a poor outcome. So I think so both of them are influence our data.
Do you have ABPM data? Ambulatory blood pressure data? Do you have?
In this registry, we don't have ambulatory blood pressure data. So unfortunately, in Korea, we cannot use renal denervation as a practice because the government did not approve. So after the hypertension 3 trial result, 2014, we cannot use this device, so we don't have any ambulatory blood pressure data. Thank you.
Okay, thank you very much for your presentation. Let's move on to the next lecture. The presenter is Dr. Kim Hai Ko from National Heart Center, Singapore. He's going to talk about renal denervation experience in Singapore. Dr. Ko, please.
Thank you, Mr. Chairman. My assignment today is to talk on renal denervation experience in Singapore. but we don't have a large experience, so I'm just going to tell you what we have done. We know that hypertension is a severe disease, and in the old days when we didn't have any drugs at all, the blood pressure can really shoot up to very high levels. But nowadays, with the excellent medications, with combinations and very good safety profile, most hypertensive can be well controlled. And it's only the minority that have resistant hypertension and is still high despite the use of multiple 4 or 5 drugs. And therefore, there is still a need for other ways to try to manage hypertension. And as we all know, the renal sympathetic nervous system is something that has in recent years been looked at, and to see how that can be modified, because the sympathetic stimulation of the renal organ will lead to increase angiotensin II and produce all the adverse effects on the heart, as well as blood pressure and the atherosclerotic lesions in the rest of the body. We know that the renal nerves innervate the renal arteries, but it's very superficial and inadvertential, as has been pointed out by various previous speakers, and that allows us to deliver radio frequency energy using various types of radio frequency catheters that is positioned into the renal artery and ablated in the circumferential fashion. And this is the older version, the simplest flex system, whereby we can ablate in sequential fashion 4 or 5 ablations over 2 minutes at a time. We know from the randomized simplicity hypertension 2 trials that there is effective lowering of the blood pressure, quite significant, shown here is systolic blood pressure reduction in office of about 30 odd millimeters at 6 months, and even diastolic 12 millimeters. So, and 36 months, it also shows a significant reduction in this chart here, showing the systolic blood pressure reduction, very marked initially, but still consistent over the 36 months. So we have also embarked on the management of patients who have very resistant hypertension, and in our early experience, we combined 2 hospitals. We have 18 patients, and basically they are hypertensives, resistant ones with the use of multiple drugs, 5 drugs on the average, and quite a number of patients are diabetics. In the early report, we showed that the patients do respond, and those that we were able to follow up in the early presentation. I'm going to show you the longer term follow-up for my heart center itself. We have 14 patients that we follow up, most of them up to 3 years at least. The mean age was 59, and most of about 2/3 were males, and quite a number, about 61% or 71% were diabetics, so quite a large proportion of patients with diabetics, which is not surprising, as they are very difficult to control with blood pressure, especially with the involvement of the renal disease as well. The serum creatinine is just at the borderline level, and the number of drugs actually is quite high here. In all patients, most of patients receive diuretics, and quite a number receive spironolactone. The systolic blood pressure was consistent with other series, 170 office, over 90 diastolic, and it was quite well matched by the 24-hour blood pressure assessment, 165 over 84. Clinical characteristics of these 14 patients, 12 of them received the simplicity flex radiofrequency ablation. We had 1 patient that had the spiral device used, as well as 1 patient with a Vessix device. The average number of ablations using the simplicity flex was equal for the right and the left. I think usually we ablate 4 or 5, but sometimes because there are accessory renal arteries, then we will ablate more on one side or the other, and on the average it comes out as equal here. We had a couple of patients who had renal impairment, not very severe, but certainly it wasn't nice to use too much contrast. So in one patient, we used the carbon dioxide assisted renal nerve radiofrequency ablation, and another patient who had contrast allergy to the radiographic contrast, we had to use solely the CO2 technique to do the RF renal vein denervation. 2 of our patients had reduced ejection fraction, and one of them was in heart failure. And I think it probably was a mistake to try to recruit them in this study, because both of them died just after 3 years. One was within 3 years of follow-up from heart failure with other complications like pneumonia and ischemic heart disease. We lost 2 patients to follow-up. One after the initial therapy, he refused to come back, and another patient after 2 years. He's still alive, that 2-year patient. The number of drugs, as I pointed out before, was 5.2 before treatment, and of which after 1 year, the number of drugs got reduced to 4.6, and at 3 years, it was 4.5, so suggestive that there could be some efficacy treatment, but the numbers that we have seen here is rather too small for us to make any definite conclusions. Spironolactone was used in 8 out of 14 of the patients before treatment, and after therapy, 3 of these 8 could be taken off spironolactone. However, another patient had to have spironolactone added on. At 3 years, 2 of the remaining 6 who were still on spironolactone could be taken off, but then another 2 of the patients who were initially off spironolactone had to be started on again. So it's not so straightforward as to tell whether the RF ablation had been very effective in this very severe hypertensive group of patients. Fortunately, the serum creatinine level on the whole did not change much, suggesting that the ablation is quite safe and, for these patients. So the blood pressure changed at 1 and 3 years. Pre-treatment, as I mentioned before, office systolic blood pressure was 170 and the diastolic was 90. And at 1 year, there was a drop of about 13 millimeters from the baseline, and at 3 years, a 24 millimeter drop total, giving a blood pressure at 3 years of 146 over 76. And similarly, the diastolic also dropped, and quite surprisingly, at 3 years, it dropped more than 1 year. And this is a graphical illustration. As I mentioned, the numbers are really too small for us to make any statistical comparisons. Just to show you the use of CO2 for the renal nerve denervation, we have a CO2 canister, and then put it, aspirate it into a bag whereby we can use to suck it out and then inject it through the normal 3-way stopcock. So just to show you, pre-ablation, we inject the CO2. Obviously, you can't inject it in above the chest level, so otherwise you can go to the head. So this is outlining the renal artery, the wires in place, and then this is ablation, and to check that there is contact, then we do another injection of CO2 and post-ablation to be sure that there's no spasm or damage to the renal artery. So again, as pointed out by several speakers, the Simplicity Hypertension 3 trial was the sort of groundbreaking trial to show that it will be very effective for patients, but unfortunately it was not to be so. The p-value was not significant, even though there was a mild drop in the blood pressure, and the 24-hour blood pressure similarly was not significant with the p-value. Possible sources of treatment failure, many authors have analyzed the outcome for this trial as well as other newer trials. There could be that it's wrong patient selection, that maybe quite a number of them had isolated systolic blood pressure in the elderly, which might not be able to respond to the renal nerve innervation. That this trial may not have ablated the branch vessels or do a complete accessory renal artery ablation, or the ablation number of runs may not be enough, or there could be poor drug compliance after the ablation. This is a whole ESC 2013 hypertension guideline recommendation. At that time, it was a 2B indication, but so far nobody else has come up with any newer recommendations. However, there are new trials of RDN going on, and as pointed out by Professor Karyu, is going to be, one of them is going to be discussed at the next ESC. So I'd like to conclude to say that renal denervation can be safely performed even in patients with renal dysfunction. Our initial series, mainly using the second generation simplicity flex, appears to show a blood pressure reduction at 1 and 3 years of follow-up, with a reduction in the number of medications used. Careful selection of patients is important, and I think it's important to be sure that the heart failure patients or patients with poor ejection fraction should be carefully considered before putting them into the trial, as they may confuse the results. Ongoing randomized clinical trials will help us to decide whether this will be the real innovative therapy in the management of hypertension. Thank you very much.
Thank you for your wonderful lecture. This is open for discussion. Comment, question? I'm interested in CO2 angiography. Usually we are really cautious to avoid air injection. That is composed of 20% oxygen, 80% nitrogen. Why is there any problem when we infuse CO2 gas?
No, there's no major issue because it's quite easily absorbed.
Easily absorbed.
Yeah. But you shouldn't inject into the head. That can cause strokes. Yeah. So below the chest is fine.
Okay, thank you very much. Let's move on to the last lecture, which will be presented by Dr. Kazumi Kariwa from Chichi Medical University, Japan. The title of his lecture is Current Status and Perspectives of Renal Innovation in Japan.
Thank you, Chairman. So I'd like to, I'm very pleased to have my talk on the current status and the perspective in the renal denervation in Japan. So this is our characteristic of hypertension and related disease in Asia. Stroke, especially the hemorrhagic stroke, is a very common than the coronary artery disease. And also the association between the blood pressure and the stroke is steeper. And it may be due to the high salt intake with high salt sensitivity. So now we are, obesity is now epidemic. The metabolic syndrome also increase the salt sensitivity. So we are prone to salt to develop the hypertension. So we need the 24 blood pressure control from the nocturnal to morning blood pressure, especially for important for us. But this shows the association between the blood pressure increase and the stroke event and the coronary artery disease risk. As shown here, the 15 millimeters of mercury increase accounts for the 1.5% increase in Caucasian for stroke events. But this slope is steeper for the Asian population. Also, this difference remains significant in the coronary artery disease. So, for developing the hypertension and higher blood pressure, it's more risky for us in Asia. So, for blood pressure reduction, it should be more beneficial for us.
So the final target of the antihypertensive treatment is not the blood pressure reduction per se. The final goal is preventing the organ damage and the target the zero cardiovascular events. But the medication is not perfect to achieve this goal because its reduction, blood pressure lowering effect, sometimes not persisted for 24 hours. So by the antihypertensive treatment, the nocturnal blood pressure and also for morning blood pressure is a blind spot of the current hypertension medications. So reservation may cover the weakness of the medication. So as shown here, this is one of the largest observational study of the hypertension patient who are treated with the arm first.
20,000 or more hypertension patients were followed for at least 2 years. 280 major cardiovascular events, both for the stroke and coronary events, including the angina pectoris with intervention, and the sadness was enrolled, were included in the major cardiovascular events. So even treated with the current hypertensive medications, we still have the 6.5 events occurred per 1,000 person year. Especially blood pressure control is much important for controlling the home morning blood pressure compared to the office blood pressure. Office blood pressure is controlled less than 130. The morning blood pressure, when greater than 145, it increases the risk 2.5 times. But morning hypertension was well controlled less than 125. Even office blood pressure higher than 150. There are no significant increase for cardiovascular events. So controlling the blind spot, the morning blood pressure, is very much important.
So this shows the history of the renal denervation. After Simplicity 3 failed, we have a very steep, very difficult situation for these clinical trials. But Spiral, the global HGM, OFMED and ONMED. OFMED result will be presented in the ESC session of the last day of the ESC in the late breaker session. And also for the Radiance globally, and in Japan, require using the ultrasound the ablation, the renal denervation was now ongoing. And also much electrode device, the EVACE, the thermo, is now ongoing. So after the HN3, all the clinical trials, we shift the primary endpoint from the office blood pressure to ABPM, especially for 24 blood pressure average, systolic average. So for this average is the most important. In our prospective study, 10 millimeters of mercury increase in the 24-hour systolic blood pressure account for the 40% of the cardiovascular events in Asian populations. Also for this ABPM could also assess the circadian rhythm and the blood pressure variability.
morning surge could be assessed by ABPM. So we can assess not only the amount of the reduction, but also we can assess the quality of blood pressure control. It should lead to the cardiovascular protection, resulting in the cardiovascular event zero. This show summarizes the ABPM blood pressure lowering effect of renal denervation. As shown here, the simplicity is two. So this difference, 7 millimeters mercury difference was the ABPM difference between the renal denervation and control arm. But the HTM3, only 2 millimeters of mercury difference. But in Japan, the final target of the enrollment was 100, but the Medtronic stopped the enrollment at the 41 patients because of the HTM3 trial. So, but as shown here, this difference was almost a 6 millimeters of mercury difference for ABPM 24-hour blood pressure. So why this difference occurs? The one of the sham operation may be one of the explanatory cause, but the simplicity 3, the drug was changed almost 40% of both the renal denervation arm and sham operation arm. But in HLJ, exchange rate of the drug was less than 10%. It may be so for the blood pressure lowering effect of the 24 systolic blood pressure is almost the 5 millimeters mercury when we assessed the ABPM. But also, as shown here, this is a different dipping status. Even the daytime was comparable. Normal dippers, non-dippers, and risers, and the extreme dippers. Especially the risers and non-dippers are important for the patient with the heart failure, especially for health patient. Heart failure with preserved EF, as shown here. This disrupted the circadian rhythm was a poor cardiovascular prognosis in heart failure patient. But the health rate, there are no significant difference. So for blood pressure reduction, and also shift from the riser non-dipper to dippers, maybe improve the blood pressure quality to resulting in the cardiovascular event protection. And also morning sun is important